Welcome to the Patient Perspectives content series, presented by the Exon20 Group, an ICAN organization. The Exon20 Group was founded in 2017 by the visionary brothers Bob and Kevin Hanlon. Led by Chairman Bob Hanlon and ICAN CEO Marcia, the Exon20 Group provides one-to-one patient navigation, oncology nursing services, clinical trial matching, and a vibrant community for patients and families living with EGFR or HER2 exon 20 insertion non-small cell lung cancer. In memory of its resourceful and generous leader, Kevin Hanlon, this charitable organization excels at improving patient outcomes, quality of life, and through its International Research Consortium is determined to cure exon 20-driven cancer. Visit us at exon20group.org. This video is supported in part by both ICAN and the Jackie Banana Foundation. The Jackie Banana Foundation was created by Jackie Chu, an NSCLC patient and world traveler who wanted all patients to have access to life-saving treatments. A 501c3 charitable organization, the JBF provides financial support to patients and families seeking treatment or bucket list travel far from home. Visit Jackie at JackieBanana.com. Last and certainly least, I'm Taylor, a cancer community advocate and patient navigator. I'll be your host for Patient Perspectives, where we will be diving deep into treatments, diagnostics, and experiences for an in-depth patient point of view. It's important to note that this is not medical advice. This content is provided for educational and informational purposes only. We at the Exon20 Group and ICAN urge anyone seeking medical advice to consult with a licensed physician. Today, we're very pleased to be joined by Pat Gilmore, a long-standing member of the Exon20 Group and a true pioneer, because Pat was one of the first patients in the EU to receive the breakthrough therapy amivantamab. It's a first-in-class, bispecific monoclonal antibody that, while originally approved in the United States for exon 20 insertion NSCLC patients, is now showing promising efficacy for other patient cohorts as a combination therapy. Now, Pat will be sharing his story, all the way from next-generation sequencing through to his experience while on amivantamab. So, welcome, Pat.
So my name is Pat Gilmore, and I come from the west of Ireland, on the periphery of Europe. And I live in a town called Tuam in County Galway, which is 20 miles from Galway City. A city that the song Galway Bay is well known across the world, having been sung by the crooner Bing Crosby. And I have lived here for the last 50 years with my family.
Do you receive care in that area, and who's your primary oncologist?
But in the context of, we'll say, my primary care first, that is at local level, I'm a patient of the Grove Medical Centre, and that is has a staff of 4 doctors, which we normally call GPs, general practitioners, and 2 nurses. I'm very fortunate to have in that practice outstanding professionals. And I tend to visit one more than the others, a lady, a doctor by the name of Dr. Una Linsky, who I find is a very professional, caring, and kind person, and is always very conscious of my medical needs and support needs. Also, in the context of primary care setting, I have a local pharmacy, Welch's Pharmacy, and the lead pharmacist there is Seamus Walsh, and he is and his staff very supportive of me in the context of my prescription drugs, and indeed in many other ways as well, in terms of giving me advice to little issues I might have that prescriptive medicines mightn't necessarily be dealing with.
Pat's referring to medication interactions. It's an important concept for patients and care teams to be familiar with. Certain drugs or supplements may have different effects in the body when taken alongside prescribed medications or treatments. Always a good idea to discuss the medications and supplements you take or plan to take with your oncology team when entering a new therapy.
Maybe just to give an example in relation to which I'll be dealing with under side effects later, skin rash. Sometimes some of that rash can flare up, and it can break out, as it were. And he gives me he makes up a healing compound for me, and it brings healing very quickly to that area. That maybe the normal prescriptive creams mightn't be as fast reacting or acting in the treatment.
You, prior to this, worked in education, is that correct?
Yeah, I worked as a second level teacher teaching 12 to 18-year-olds in mixed setting, boys and girls. And there I taught history and English and some Latin in the early years to these students. And then in the year 1989, there were two schools in the town where I was teaching, and they amalgamated, and I was appointed principal of that amalgamated school. And that actually was an interesting challenge for me, because I had to lead the integration of two sets of staffs, two sets of parents, two sets of students, and more significantly, two cultures. And that I found challenging, but I found also very rewarding when, after a period of time, the amalgamation seemed to be seamless, and we moved on as if the two schools did not exist previously in that context, and we were now a single amalgamated school.
Moving from educating youngsters to actually running several schools was a bit of a code switch then. If I recall correctly, you had retired.
Yeah, I retired after 39 years service in teaching in 2007, which seems to me a long way away now. But I didn't really retire. As an archbishop said to me on one occasion when I was congratulating him on his retirement, he said to me, "Pat, oh, I'm not retiring, I'm just changing jobs." And in many ways, that's what happened to me, because I got involved in education at a national level, working with management bodies, in particular Education and Training Boards Ireland, which is a representative body for the 16 education and training boards throughout the country, and also the Teaching Council, which is the regulatory body for teachers in Ireland, teachers at all levels. And they are also served on the disciplinary committee, because while nearly 100% of teachers teach at very high standards, you will always have a little percentage that will stray and need to be corrected.
So this steering at a national level, was it more work than prior to your retirement at times?
It was more, if you like, engaging in a sense that it was a new learning, it was a new experience, and it's new engagement with other stakeholders of a representative nature at national level. Mm-hmm. So you're dealing with the bigger picture and bigger picture issues, and they are then distilled down to the various units of education.
Can you tell us a little bit about how you were diagnosed and what you were experiencing prior to that diagnosis?
I suppose I should put it in the context of the COVID pandemic, because in many ways the COVID pandemic ended my career, my second career serving at national level, because we had, if you like, a close down of all operations. And actually I recall the date in Ireland that was officially announced by our Taoiseach, Leo Varadkar. It was the 12th of March 2020. And in many ways, that ended my career, my second career, as it were. And then a year later, or close to a year later, on the 5th of March, 2021, I was diagnosed with lung cancer. And that truly turned my world upside down.
The lead up to that, what put you in the doctor's office at the height of the pandemic were some symptoms, correct?
Yeah, I had, after Christmas of 21 and leading into the new year in 22, I noticed in the morning bringing up, coughing up a little phlegm and spitting it into the toilet bowl. I didn't think much of it until I observed on one or two occasions that it contained a red bloodstain. And that gave me cause for concern. So I mentioned it to my two daughters, Aoife and Aisling, and they said, "Dad, don't worry, it's probably a nasal drip you're having, and you'll be okay." So they told me that, they gave me that message in the morning, but in the evening, they called me to tell me I had an appointment with Dr. Una next morning.
Huh.
So they took it seriously, and they wasted no time, and I went to Dr. Una on the following morning, and I told her my story, and she said, "Pat, there's no point of me looking at you. I will have to send you to a respiratory consultant for a consultation." And so she made the appointment for me, and within a few days, I had an appointment with a respiratory consultant in Galway Clinic, which is a private clinic. And he gave me the same message as Dr. Una. He said, "Pat, there's no point in me looking at you. I'll have to put you through the diagnostic process of scanning." So he arranged a CT scan for me. And shortly after he got the results of that, which he didn't share with me, but he shared it with my daughter, Aisling, who at that stage was quickly to become my advocate, that he suspected something and he wanted to do a bronchoscopy. So he did a bronchoscopy, and seemingly that confirmed his view that there was a cause of concern with my right lung. And then he did a biopsy under CT scan surveillance. And that led to my diagnosis on the 5th of March of lung cancer, a tumor on my right lung. And it had also spread into my lymph glands on the left and right of my chest.
In terms of the initial diagnosis, when was the tissue sent off for next generation sequencing?
I didn't get any great clarity about, if you like, timelines in relation to that. Mm-hmm. But it would appear that it was sent for next generation sequencing within a reasonable time frame, because I recall that as soon when I met my oncologist, he confirmed to me that I had grade 3 cancer and that I had also a PD-L1 protein. It had a 78% presentation, the actual PD-L1, which he said would be important in enabling me to have immunotherapy at a subsequent date.
And so PD-L1 expression of greater than 70%, 78%. You also have some mutation drivers, one of which is our exon 20 insertion.
Aisling, my advocate, and myself only became aware of that later, that arising from that next generation sequencing, that I had a driver mutation, EGFR Exon 20. And in many ways, for me, that medically, it didn't mean much to me because I really didn't understand what that really meant. And it was only with the passing of time I realized the significance of that it was a specific mutation. And as a consequence, it would need a specific therapy to, if you like, treat it. And I subsequently became aware too that such a therapy at that point was not available.
In terms of the other mutation drivers, are there any others that were detected in your next generation sequencing?
There was a small element of ROS1, but insignificant.
So EGFR exon 20 insertion, ROS1, and then a PD-L1 expression of greater than 70%.
Yeah.
At what point did you come across the exon 20 group?
It was actually through Ashling's research, and you'll know from now on that Ashling is my advocate. She did extraordinary research into developments that were taking place in clinical trials in America. And through that research, she came across the group ICAN, and also came across the name Marcia as the chief executive of that body. And she kept digging, as it were, and eventually found that there was a subset group within that ICAN, Exon 20 group, and that Marcia was also involved in the leadership of that group. She actually made direct contact with Marcia through email and subsequently through a WhatsApp phone call. And that was a very, very enlightening experience and hopeful experience for me, because we were speaking to a person with enormous experience and we saw her as a huge resource in terms of her knowledge, her expertise, and her up-to-date knowledge of developments in the States with regard to the various therapies and the various treatments and clinical trials and all of that. And she then introduced us to Exon 20.
Your diagnosis was the 5th of March in 2021. I was hoping you might take us through some of your treatment prior to discovering and beginning your treatment with amivantamab.
Yeah, actually, I commenced my, if I call it primary treatment, which was a combination of chemotherapy and radiotherapy. I commenced that on the 19th of April, 2021, which actually was my birthday. And I recall that the most positive feeling or experience I had that day was all the oncology nurses coming in the door with a birthday cake singing happy birthday to me. And that definitely made the experience a little bit more acceptable to me. So in all, I think I had 30 days radiotherapy under a very, very excellent professional radiology oncologist, Professor Frank Sullivan. His plan was extraordinary, well planned for me, because he wanted to avoid as much as possible any collateral damage from the radiotherapy treatment. And he went to great lengths to protect me in that regard from scarring. And my oncologist collaborated with him in the context of my chemotherapy plan. So that lasted 7 weeks. I actually did very well on that, and I really didn't have any major side effects during that 7-week treatment program. But funny, Professor Sullivan did say to me, Pat, you're not out of the woods yet, you know, because you could have, if you like, the accumulative effect of both treatments at the end of the treatment. And he was right. I had 4 or 5 days, if you like, where I had a lot of side effects, but I got through it. And it would be a combination of, you know, things like diarrhea and constipation and pain and things like that. But I was well looked after and well advised from the chemotherapy suite with regard to treatments for SEN.
So following chemotherapy and radiation, you had follow-up scans.
So I had a follow-up scan that stated that my cancer was stable, as it were, or my treatment was making the cancer sites stable. And then in the first week in July of that year, they commenced me on immunotherapy using a new drug there as well, I think at the time, durvalumab. And I had 3 sessions of that treatment. And then, regrettably, the treatment didn't work out for me. And I began to have issues with my lungs, including shortness of breath and fluid in my lungs. And I was diagnosed with pneumonia. And I was given antibiotics, oral antibiotics, to take it home for the first week. And then on the second week, when they did an x-ray on my lungs, they found it was still there. So they admitted me as an inpatient in the Galway clinic, and they treated me with antibiotics on the drip. Yeah, at the end of that treatment period, my oncologist put me back on the immunotherapy, and convinced me back on the immunotherapy. And I had another session, and again, on this occasion, I had an acute reaction, and my lungs, when I was out for a walk, my lungs began to collapse, and I called Aisling, and she called the ambulance, and I really was in a bad state, so I was quickly hospitalized for my condition. And during that hospital stay, I was re-scanned, and it was confirmed that I did not have pneumonia, but I had pneumonitis. That led to, in discussion with my family, to us changing our oncologist and meeting with a new oncologist who accepted me as a patient. And we went on from there. You know, it's very important in the context of the relationship between the patient, the advocate, and the consultant, you know, that it's a relationship based on listening and good communication and understanding and acknowledging the professionalism of the oncologist, but acknowledging too that the patient and their advocate may have, they have the experience of going through it and may have learned along the way, and that there's no, if you like, that it's not kind of devaluing the role or the professional role of anyone, but rather doing what people might think is best for the patient.
It should be the patient, the caregiver, and the oncology team that work really well together, I think is your point.
Yeah, and it's no threat to anybody, but rather it's to the benefit of the patient, and the patient must be at the center of everything that we do and everything that we conversate about.
So here we are, July 2021, and you have discontinued taking the immunotherapy, and you have pneumonitis. So you need to let that heal, as well as it sounds like you're going to meet a new oncologist for your care.
Yeah, and as a consequence, I was put on a course of steroids, and that steroids, I think I was on that course of steroids up to the end of October.
So steroids are indicated for pneumonitis. Was it prednisone?
Yeah.
Okay, so a prednisone, do you remember the dosage?
At the maximum dosage, it would be 90 milligrams.
So high dosage of prednisone is how they start off treating pneumonitis, and then you come down in dose over the coming weeks, correct?
Yeah, over a period of time, you come down on a percentage basis, week on week, until you really get down to very low doses.
Having moved oncology teams, once the pneumonitis is under control, it's time to be exploring their recommendations for your next line of treatment. Yes,
and I had a scan under my oncologist, Professor Paul Hanlon, at the end of November of 21, and the results of that scan showed up the growth of 2 nodules on the original site, cancer site. Now, in his examination of those nodules, he couldn't say with accuracy whether they were malignant or not, and he said that they were too small to actually test by biopsy. And he would wait until we commenced new treatment. He was wondering possibly then maybe to return and go back on immunotherapy. And my daughter had a conversation with him, and arising from that conversation, she raised the new development of the new drug, amivantamab, which he was familiar with, and that she also drew his attention to a doctor who was involved in the development of the drug in the United States, a Dr. Jeruska Nadu. And arising from that, there was no further development on where my treatment was going until January 2022. Anyhow, the outcome of all that was a conversation between Professor Donlan and Dr. Jeruska Nadu, and also a meeting between myself, my advocate, and Dr. Jeruska Nadu in January of 22, where she told us that in consultation, that Professor Donlan had now decided to recommend that I be treated with amivantamab, provided I would get access to it. And as a result of his engagement with whoever makes that decision, I was approved for amivantamab on compassionate grounds. And I think possibly the compassionate grounds were probably influenced by the fact that new nodules had emerged after the original treatment, and that the original treatment mightn't be adequate or sufficient to control them now. Now, that's my view. I'm not giving the view of the oncologist there. And to cut a long story short, I started on amivantamab on the 2nd of February 2022 under the management managed by Professor Donlan and the oncology suite at the Galway Clinic. And I'm on that drug since. My next treatment date is actually this day week, next Friday week. And Professor Donlan and his registrar, Dr. Giuseppe, and his oncology nurses have been outstandingly supportive of me.
And in terms of your scans and disease progress while on this drug now for 19 months and some change, what have your scan results looked like while on amivantamab?
If I go to my second last scan, which would be 5 months ago now, at that stage, Professor Donlan advised me that there was no evidence of cancer in my system. But in my most recent scan, the result was the same, except on this occasion he did say that I had a small, I think it's a pleural effusion in my right lung, but he wasn't concerned about it.
So right now, a small sized fluid has formed in your right lung. But other than that, you have no evidence of disease. Is that correct?
No evidence of disease, no.
The heralded NED. It was a bit of serendipity upon which you happened upon amivantamab. Would you mind telling us how you first heard of this groundbreaking new treatment?
I was listening to the radio, and I switched on to a station known as News Talk. And on it was a program hosted by a well-known radio presenter in Ireland, Pat Kenny. The title of his morning program is Today with Pat Kenny. And at the end, as he was concluding a particular topic, he said at the end of that topic that after the break, he said, because this January is Lung Cancer Awareness Month, I'm going to be talking to an eminent oncologist involved in the development of new drugs and clinical trials by the name of Dr. Jeruska Nadeau. And then he went into the break. So after the break, he introduced Dr. Nadeau and spoke with her for a considerable period about lung cancer, and particularly the hopes that the development of new drugs brings to lung cancer patients. And she shared with him particularly her engagement with the development of amivantamab in clinical trials. Dr. Nadeau, as it transpired, I learned as well, was the head of lung cancer in Beaumont Hospital in Dublin. And then at the end of that interview, I didn't even reflect on it. I just thought it was very interesting stuff, but maybe it didn't involve me. And immediately afterwards, my daughter, Ashling, my advocate, called me and said, "Dad, you wouldn't happen to be listening to Pat Kenny?" Well, I said, "It's amazing. I was." And I said, "I don't know when did I listen to Pat Kenny previously." And she said, "Did you hear the oncologist, Dr. Jeruska Nadeau on?" I said, "I did." "And did you hear her talk about the drug amivantamab?" I said, "I did." Well, she said, "I want to tell you, you have an appointment with her in Beaumont Hospital next Wednesday." And that was about 5 or 6 days away. And I couldn't believe it, how I actually tuned into this program totally accidentally and coincidentally, how she was listening and how she called me and how she had been following these developments and how Dr. Jeruska Nadeau was on her radar.
So, and under a month following you hearing about amivantamab for the first time on a random Pat Kenny radio show, within a month, you were having your first treatment of amivantamab in your local Galway facility.
Absolutely, and as I said, it's an amazing story, and what is also amazing is the reception that Dr. Nadeau gave us when we visited her in our I won't use the word rooms, because generally that's an upmarket kind of suite that you hear in private clinics. I say that respectfully, but she had a little plain office with a few ordinary chairs on the table and a computer on the table. And she was so welcoming. And she even advised us that she knew an awful lot more about me than I would understand, because she had a conference with Professor Donlan and herself with regard to my future treatment.
So you've met with Dr. Nadeau, and she and Professor Donlan have now discussed amivantamab as a potential treatment for you. You were approved for it, potentially based on the nodule progression between July and January. And you walked into the Infusion Center on February 2nd, right outside of Lung Cancer Awareness Month, for your first treatment of amivantamab. Tell us about that first infusion.
And they advised me that in terms of the first infusion, that there was a high possibility that I may have a reaction. And that if I did, not to worry, that they had all the emergency kit ready to deal with that situation. So they started me started the infusion, and I nearly immediately had a reaction. And the nurse had told me in advance that they would be very aware of it very quickly from, if you like, the how my face and that would respond in the context of the reaction.
How did you feel when you started having this reaction?
I just feel, I think what I felt was getting weak and maybe having certain difficulty with breathing, but I cannot be accurate on that either now. But I recall maybe these are some of the symptoms I experienced.
So once the infusion started, it was a short amount of time before you started feeling weak, some shortness of breath, but then the nurses also recognized that your face was flushing or turning red. And so they stopped the infusion.
Yeah, and in their emergency pack they had oxygen and steroids, and they gave me whatever they had to do with that. I wasn't aware, but I quickly recovered from the reaction.
And they were able to restart the infusion.
And they said, good. So that tells us now that we must reduce the dose considerably of the infusion. And they said as a consequence of that, it will take a much, much longer period of time, your infusion, your treatment on your visits for treatment. So in all, the infusion now, my treatment now lasted between 8 and 8.5 hours on each treatment day. And that continued, I'd say, for about 4 to 5 months. And Professor Hanlon was very slow to increase it because he didn't want to risk any setback. But then, in consultation with his registrar, he slowly began to increase the infusion rate over a long period of time. And now I've arrived at the stage where I receive it in 2 hours, 40 minutes.
Did you ever experience an infusion reaction again after that first reaction?
No, just one reaction, and had no difficulty after that. And even when I talk about my skin rash, I did have my treatments cancelled on 3 occasions because I had a flare-up of skin rash, and on the advice of the registrar, thought it was a good idea not to proceed. And then I was concerned, would I have a reaction after the break, but I never had.
We do know now that infusion reaction tends to be a one-time thing only for patients that experience it. And it is quite common. Greater than 60%, I believe, are the numbers coming out of the amivantamab clinical trials, have a mild reaction to the first infusion. But after that, they don't experience it again. Now, you started to mention skin rash. Let's talk about side effects next. As with any treatment, whether it be an antibody treatment or immunotherapy treatment or traditional chemotherapy treatment, there are side effects, and amivantamab certainly has its side effects for patients. Can you speak to each of those side effects individually? Let's start off with skin rash, which you mentioned disrupted treatment 3 times for you.
So my first obvious side effect was skin rash. That is in my trunk or upper body, my neck and my face. And also it extended to my scalp. I don't know if I refer to that as scalp rash. Mm-hmm. And I suppose when I saw that first, I was concerned because it was a new experience for me, dealing with skin and that type of these type of skin issues. But the oncology suite, the oncology staff in the chemotherapy unit were very helpful, and they prescribed a range of topical creams for me to use, starting with, and maybe I don't know how these translate across jurisdictions, but I had Fusibet to deal with my upper body because it is a fair strength in steroids, and then a different cream for my face, Fusidin H, because I think it possibly has less steroids and less damaging to the skin. And also a cream for my scalp, Dermavet, Termovate. And I used the skin topical creams in conjunction with moisturizer and sunblock, and also aloe vera gel. So when I went to my dermatologist to support me with my skin rash, She confirmed that I use my topical creams first, then sometime later, half an hour, to use my moisturizer, and then half an hour later, sunblock. So as to allow each, particularly not to interfere with the performance of the creams. And then if I felt any discomfort, to use aloe vera gel, because it's kind of a coolant. But amazingly, with the skin rash, excuse me now, I never really did have pain, and I never did have itch. And whether that is how the treatments were working in my favor or not, I'm not too sure. And also then prescribed for me was the antibiotic doxycycline. And I take that on a permanent basis as, if you like, to help with reduce the effects of the skin rash itself. So with regard to my scalp, I use the
Dermovate?
Dermovet, and also my pharmacist advised me with regard to shampoo to use, Elave, E-L-A-V-E, and also to use Silcox base for shaving, rather than soaps or any other type of shaving creams. And they have worked very well for me in terms of protecting my skin. I did have flare-ups, and as a result of, on 3 occasions, my treatment was cancelled. And basically, it was where the Dr. Giuseppe wasn't happy because it looked rather raw or nasty, the flare-up. And he said it's better not to continue. And these breaks did help to alleviate the problem and to reduce the toxicity because of the time lapse between the two things. The next side effect, which was very challenging, was my nail beds. Both my hand nails and my toenails, but more so my toenails. And at least three of them got very badly infected and were creating great difficulty for me in terms of walking. And I went to a specialist in that area, and he recommended removing particularly the toenails that were highly infected. And he did that. And at the same time, talking to one of the oncology nurses in the cancer unit, she gave me advice on how I might help to, if you like, relieve the possibility of infection in the nail beds by diluting apple cider vinegar in warm water and bathing my feet in it on a regular basis. And also by just putting my fingernails into the neck of the bottle and using the undiluted apple cider vinegar for a few seconds. And amazingly, that has worked very well for me, both for my toenails and my fingernails.
Did you experience any issues with joint pain?
Yeah, I also then had an experience with joint pain in my knees, in both knees. And again, I went to a specialist to get some advice on that. And he could see it as a possible side effect of the treatment. But his recommendation was that it was something that would, he thought at the time would improve if I was to get a pedal bicycle and to exercise on it on a regular basis each day. And I did that. And I must say it worked very well. And over a period of time, the pain disappeared, and it's no longer a problem.
Were there any other issues with mobility or your legs?
The other issue I had with more so my right leg than left leg was fluid in my leg, and it would flare up now and again, and I got a manual lymph drainage treatment, and that was very helpful. And also, when I was resting or watching television, or when I went to bed at night, I always put pillows or cushions under my legs and raised them high, so as to try and create natural drainage away from my legs. And also, on the advice of the person who did my lymph drainage, I wore from time to time compression socks. But the worst period that I had that was when I was flying from Ireland to the States and back, because obviously with changes in cabin pressure, it seemingly impacts on one's fluid.
Any sort of fluid buildup, whether it's well inside our body or on our limbs, is going to respond to pressure changes. And so it's an important watch out for patients that might have a pleural effusion or other fluid buildup. If they're planning to fly, to ask their physician if there are any measures they should take prior to that flight. There's a litany of what we would call common side effects associated with EGFR targeted therapies like amivantamab. But specifically, we're seeing vision being an area of interest in terms of side effects. Did you experience any vision side effects?
Yeah, I had that experience too, of feeling of not being happy with my eyesight and noticing my vision a bit blurred. And it's very hard to describe how that represented itself, but I was aware of it.
Vision changes tend to present further on in the course of a treatment, at least with other drugs, as well as amivantamab. At which point in your treatment did the vision changes arise?
Looking back, I'd say it was about 4 to 5 months after the commencement of my treatment. And I discussed it with Professor Hanlon, my oncologist, and he recommended I see an ophthalmic surgeon. And I did, and he did a survey of my vision and was of the opinion that I did have an issue, and he prescribed steroid drops for me. And that actually, over a 2-week period, and that helped greatly to resolve the issue. When I reverted to him, he was satisfied that the issue was resolved, and it didn't reoccur.
You'd mentioned flying to the United States during your treatment journey. Was that a trip for tourism or visiting any friends and family?
It was visiting my son in America and his family, and it was a visit that really restored a level of normality to my life that I really was pleased with. That all of a sudden, I had no thoughts of amivantamab or treatment or cancer or anything like that. It was great just to leave that and experience real normal living, visiting my son and his kids and wife, and holidaying and enjoying myself.
In terms of other side effects associated with amivantamab, if you wouldn't mind very quickly, just let me know if you had any of these side effects. Fatigue.
Yeah, I have fatigue from time to time, but at this stage, I just accept it, fatigue, and I don't differentiate between that fatigue and normal tiredness now. So if somebody says you're tired, I say I am, but I don't say I'm fatigued.
What about gastrointestinal issues such as diarrhea or constipation?
No, I'm very normal. I'm very normal in all that area, and I'm careful to mind myself and to medicate if appropriate.
What about mucositis or mouth sores? I know you had some rash and paronychia, some nail bed issues, but did you experience any issues within the mouth?
No experience, no issue with mouth sores or anything in relation to that.
And in terms of your appetite, since you've been on amivantamab, have you noted any changes in appetite?
No, because what I noticed, my appetite hasn't changed, and I notice my weight is very consistent, and they weigh me at every treatment day. And before I go on the weighing scale, I say there's no need to weigh me. I'll tell you exactly my weight, and it normally is within. It's very close to what I say In fact, actually, it's 95 kgs.
Have you had any bouts of dizziness, headaches, or vertigo while on amivantamab?
No, I can't say, I can't recall I have. But at a very odd time, I would feel unstable on my feet. But that's whether that's coming from my head or my feet, I'm not too sure. But and that happens very odd time. And now that's where actually maybe fatigue is kicking in, and I'm not acknowledging it.
Those of us who aren't on cancer treatment often feel fatigued as well. So it's difficult to differentiate what's a pronounced side effect and what's just the general course of the day in a lot of these cases. All side effects are difficult in their own way. You've provided some strategies that your teams have provided, as well as what's worked for you in managing those side effects. If you had advice for a patient who's about to start amivantamab treatment, what advice would you give them?
It's understandable if people have fear. It's understandable if people have concerns. However, looking back now, I find that if one can live in the moment and say, look at, let's see how things develop. I know I'm not going to escape side effects, but let's make sure I have in place sufficient expertise to support me and guide me as these side effects emerge. And in any management of any situation is better than panic, or better than worry, because then that will generate new problems. And I'm not saying for a moment now that over the period of my 19 months that I didn't have days when, as my Dr. Una says to me when I meet her, Pat, how was your mood today? When I didn't have days where my mood wasn't as good as I'd like it to be. Because it's in the nature of the disease, cancer. It's also part of the treatment. And you know, one has to try and deal with that and accept it. I have avoided taking any medicine to support my, and I'm not saying there's anything wrong with that either, but I try to manage it within my own personal resources. And that for me, part of that, and I'm lucky that I like walking, I like gardening, I like exercise, and I'm very lucky to have in my own town of Tuam Cancer Care to provide a range of services that I partake in, like physical therapy 1 hour a week on Monday morning of each week. An extraordinary experience and session of engaging with one's own physical fitness under the guidance of professional physical therapists. I also go to attend reflexology sessions, massage, and I also, in the early part of my cancer days, had some counselling from Tuam Cancer Care. I would advise, I would give this advice that if there are support groups within your locality, within your village or town, look them up. They provide very valuable services at no cost to the patient. I do my best to at least get in 2.5 kilometers a day. And I time myself with my Apple Watch. And I always bring a stick with me, just as support. Not that I actually need it, but I find it some type of a psychological support to me when I'm out walking. And I generally average my walk at 13 minutes a kilometre. So that would be 2.5 would be about 34, 35 minutes a day. And I like to hit a golf ball when I get a chance. I find that's very good for my, I don't know what, for my physical and mental health. And I think when I hit a good shot, I'm Rory McIlroy.
Yes. Pat, I really appreciate you taking the time today to share with us your experience on amivantamab. As we noted, you are a pro at this point with a very young drug being on it 19 months. I mean, you've provided a wealth of information today, and we thank you on behalf of the Exon 20 group and ICAN. Thank you, Pat Gilmore, for sharing your experience.
Let me finish with a few points. My journey would have been much more difficult was it not for, in the first instance, the support of my wife, Anne, who was with me every step of the way, my daughter, Aisling, her husband, David, and their twins, Mason and Sophia, my daughter, Aoife, and her husband, Declan, their children, Ava, Dara, and their twins, Emily and Isabella. And also, let me say thank you to my son, Ronan, and his wife, Jessica, and their children, Molly and Madison, who gave me such a wonderful holiday in the States last summer. And finally, then, let me mention my brother, Michael, who was my permanent taxi for much of the period. Let me say the journey would have been much more difficult without the support of my heroes. And in that context, Aisling, my advocate, was an extraordinary support together with the other members of my family. So too are my friends. So too the Exon 20 group, and I particularly reference Marcia and Carm. My multidisciplinary professional team that actually Aisling and myself put together. Because we're in a private clinic, we don't have access to the public, to the multidisciplinary team that you'd find in a public hospital. I want to pay tribute to my oncologist, Professor Paul Donlan, for his management of my cancer, my scanning arrangements, and managing my treatment and my consultations. And my extraordinary oncology nurses that work in the oncology unit. They're real professionals. They really are understanding of the variety of treatments that they discharge every day of the week. And they do it with great courtesy, great professionalism, and great kindness. And June Cancer Care I have mentioned already. Finally, I would say, the road out of cancer isn't easy, but it's the only road to recovery. And we have to try and continue to travel that road.